Hi friends, in your clinical practices, you might have come across many patients with abdominal incisions. So in these abdominal incisions, you know which incisions can cause the maximum post-operative pain for the patient. So to know and to get the answer for this question, continue watching this video till the end, and I'll be explaining about this point in the explanatory session for a question what I'm going to ask in this session. So welcoming you all back to our nurse channel, and hope you all are preparing well for the upcoming AIIMS NORCET and the ESIC examinations. So the application has already arrived, and I request everyone to do it fast. And any doubts or any clarifications regarding the application and any points in the need to be discussed further, you can approach us anytime through our comment section. And any doubts regarding the application, you can go through our website also. So straight away we'll move on to the another set of questions. Before that, whoever not yet subscribed our channel, kindly subscribe our channel. Kindly watch the video till the end without skipping, and share about this platform to your nursing friends, and kindly enable the bell button, and you will be notified when new videos are arrived. Okay, so straight away without losing time, we will move on to the another set of questions which are very important. So see the questions. So let us begin this new session with an interesting question from ENT. So the first question for you in the screen right now. So the question is, the most common cause of peripheral episodic vertigo is. So the question is, most common cause of peripheral episodic vertigo. So you know that there are several types of vertigo, in that peripheral vertigo, then central vertigos, like that. Some divisions are there that you can refer later. So here the question is, most common cause of peripheral episodic vertigo. So the options are: option number A, Meniere's disease; option number B, acoustic neuroma; option number C, benign paroxysmal positional vertigo; and option number D, vascular occlusion of labyrinthine artery. So what is the answer? The most common cause of peripheral episodic vertigo. So the answer is option number C, that is benign paroxysmal positional vertigo, that is BPPV. Okay, so we'll have a small explanation regarding these options. First of all, BPPV. So benign paroxysmal positional vertigo, it is a common inner ear disorder that causes vertigo. So you know that peripheral vertigo is most commonly due to this benign process, and benign paroxysmal vertigo is by far the most common cause of peripheral vertigo, and it occurs when calcium crystals called the otoconia become dislodged from their normal location in the utricle. And utricle, you know that it is a sensory organ of the inner ear. So what happens then, when the crystals land in one of the semicircular canals, the canals may send the wrong signals to the brain, and this confuses the brain and lead to BPPV symptoms. Okay, so this is the way the BPPV vertigo is happening. So the main cause is the dislodgement of a calcium crystal called otoconia, and it is getting stuck in the semicircular canals. Okay, and that can result in the BPPV symptoms. And the other reasons for its manifestations are psychological distress, such as high levels of anxiety, depression, and somatization may play a role in BPPV. So from this also you can expect questions like, which type of vertigo are can be exacerbated with psychological distress. Okay, so that is the benign paroxysmal positional vertigo. I think from this slide you are getting information regarding benign paroxysmal positional vertigo. Then another option was the Meniere's disease. So this is very common. Meniere's disease is a disease of the inner ear that is characterized by potentially severe and incapacitating episodes of vertigo, tinnitus, hearing loss, and a feeling of fullness in the ear. So it is characterized by severe and incapacitating episodes of vertigo, tinnitus, hearing loss, and a feeling of fullness in the ear. So typically only one ear is affected initially, but over time it can in both ears also can be involved. And the episodes generally last from 20 minutes to a few hours. And one more point, the time between the episodes varies, and the hearing loss and the tinnitus can become constant over the time. So these are some other information regarding the Meniere's disease, but the common cause for the peripheral vertigo is BPPV, that already we have explained. So the other options, acoustic neuroma. So acoustic neuroma means it is a non-cancerous, usually slow-growing tumor that form along the branches of the 8th cranial nerve, also known as the vestibulocochlear nerve. So in acoustic neuroma also, this nerve leads from the brain to the inner ear and branches into the divisions that play important roles in both hearing and balance. And here the problem issue is with the problem with the cranial nerve. So there is a central cause. So this is a here the vertigo cause is a central cause. So that's why it is called as a central vertigo. Okay. So moving on to the second question in our series, that is from the community health nursing. So the question is, what is the reason behind giving BCG vaccine always in the upper aspect of left arm? So why BCG vaccine is always giving in the upper aspect of left arm? So from the question we are getting our information that BCG vaccine always should be given in the upper aspect of left arm. So the options for this question are option number A, more effective in left arm. Option number B, may cause more adverse effects in the right arm. Option number C, to maintain uniformity. And option number D, it is not essential, it can be given in a right side. So why BCG vaccine is always given in the upper aspect of the left arm? So the answer is very simple. Answer is to maintain the uniformity. Okay, so this is the recommendation. The BCG vaccine is given just under the skin, that means intradermally, usually in the left upper arm. So this is the recommended side, so that excuse me, so that small scar left after the vaccination can be easily found in the future as evidence of the previous vaccination. Okay, so by seeing the child, we can find out like the previous vaccination, the BCG vaccination has been done or not. So that's why to maintain the uniformity, the BCG vaccine is always giving intradermally over the left arm. Okay, upper aspect of the left arm. So that's all regarding the second question. We will move on to the third question in our series. The question is, which one was announced in 2003 with the objectives of correcting regional imbalances in tertiary healthcare services? So this question is regarding a Yojana. So in the question it has given 2 points. The first one is it is launched in 2003 and the objective of that program, that is regional imbalances in the tertiary healthcare services. So which was that program? So the options are option number A, the Pradhan Mantri Swasthya Suraksha Yojana. Then option number B, Rashtriya Swasthya Bima Yojana. Option number C, Janani Suraksha Yojana. And option number D, Pradhan Mantri Jan Arogya Abhiyan. So in 2003, correcting the imbalances, regional imbalances in tertiary healthcare services. So which Yojana? So the answer is option number A, that is a Pradhan Mantri Swasthya Suraksha Yojana. So we will have a small explanation regarding all the four Yojanas, what I have explained here. So the first one is the Pradhan Mantri Swasthya Suraksha Yojana. So PMSSY, the short form is PMSSY. It was announced in 2003 with the objectives of correcting the regional imbalances in the availability of affordable or reliable tertiary healthcare services, and also to augment facilities for quality medical education in the country. So the main two objectives are for correcting the imbalances in the availability of tertiary healthcare services in the regional levels, and to improve the quality of medical education in the country. Okay, that is a Pradhan Mantri Swasthya Suraksha Yojana. So the other options, the next option was the Rashtriya Swasthya Bima Yojana, that is the RSBY. It has been launched by the Ministry of Labour and Employment, Government of India, to provide health insurance coverage for the BPL families, that is the below poverty level families. So question can be asked like this also, which Yojana provide health insurance coverage for BPL families? So objectives of RSBI is to provide protection to the BPL card holders from financial liabilities arising out of the health shocks that involve hospitalization. So it has started rolling from 1st April 2008. Okay, so 2008, 1st April 2008, that is a Rashtriya Swasthya Bima Yojana for the BPL patients. Okay, so this is also important. Now we will see the next option. Janani Suraksha Yojana. So JSY. So it is a safe motherhood intervention under the National Health Mission. Okay. So this is under National Health Mission. So it is being implemented with the objective of reducing maternal as well as the neonatal mortality by promoting institutional delivery among the poor pregnant women. And the scheme was launched on 12th April 2005. So Janani Suraksha, from the name itself you can come to a conclusion like it is for the maternal and neonatal benefit to promote institutional delivery, which was launched in 12th April 2005. And the last one, that Pradhan Mantri Jan Arogya Abhiyan. So it is launched on 23rd September 2018, and the main objective of PMJAY will provide rupees 5 lakh health insurance for the secondary and tertiary hospitalization. Okay, so this Ayushman Bharat Yojana will benefit around 50 crore poor people and provide them cashless and paperless treatment in the hospitals. That is the Ayushman Bharat Yojana, which comes under this Pradhan Mantri Jan Arogya Abhiyan. Okay, it was launched in 23rd September 2018. Okay, so from this question you are getting information about the 4 important programs which were launched by Pradhan Mantri during the last 10 years. Okay, so that's all regarding that question. Very informative. Moving on to the 4th question in our series. Partial or total separation of previously approximated wound edges due to a failure of proper wound healing is termed as. So from the question, partial or total separation of the previously approximated wound edges. Previously approximated means already sutured wound. So there will be partial or total separation is happening. Why? Because of the failure of proper wound healing. And this type of separation is termed as dash. So the options are option number A, evisceration, option number B, dehiscence, option number C, laceration, and option number D, shearing. So what is the answer? Partial or total separation of previously approximated wound edges due to a failure of proper wound healing. So the answer is option number B, that is dehiscence. Dehiscence. So dehiscence, what is dehiscence? So dehiscence is a partial or the total separation of previously approximated wound edges due to the failure of proper wound healing, and this scenario typically occurs 5 to 8 days. Okay, 5 to 8 days following the surgery when the healing is still in the early stages. Okay, and a wound can become separated when the stress or the tension or the pressure overcomes the strength of the stitches or the staples which are used to close the incision. And this can happen from coughing, then lifting while doing the strenuous exercises or other movements or the actions. It can also occur if the wound was not closed correctly. Now we will see the other options what I have given in this question. So dehiscence, I think it is clear for you. Now we will see what is an evisceration. This is also very important. So evisceration is the uncontrolled exteriorization of the intra-abdominal contents through the dehisced surgical wound outside of the abdominal cavity. So evisceration may occur from omentum, but it is of the great concern when the bowel protrudes through the separated fascia. So in case of the abdominal organs, the evisceration is explained here. So the wound is, if the wound is already dehisced, what is happening is the exteriorization, that is some organs or the contents of the abdominal cavity can come out through the dehisced wound. So that is known as the evisceration. And some more important points. So in case of the evisceration, do not attempt to replace the organs back inside the body. Instead, cover all exposed abdominal contents with moist, sterile towels and cover with an occlusive dressing. So the intestine, liver, spleen and stomach are commonly involved in evisceration. So you know that these points are also very important. So if an evisceration happens, what we have to do is we should not replace the organs back to the position. Instead we have to cover with a moist sterile towel and we have to give an occlusive dressing. And which all are the organs which are involved in the evisceration, commonly involved? These are the intestine, liver, spleen and stomach. Okay, I think so that also is clear for you. Now we will see the other option, that is a laceration. So laceration, it is a wound that is produced by the tearing of soft body tissue. Okay, here tearing is happening, and because of that this type of wound is often irregular and jagged. So a laceration wound is often contaminated with bacteria and debris from whatever object caused the cut. Okay, so that is this laceration is not related to dehiscence and evisceration. Okay, dehiscence and eviscerations are the two options that may confuse you. And the final option was the shearing wound injury. So if shearing wounds occurs when the forces are applied to the body tissues or parts that cause the tissues to move in opposite direction. So when there is an opposite direction and the friction can happen, and that can result in the shearing wound injury. And about this shearing wound injury and the bed sore formation because of the shearing force, I have already discussed in our old videos that you can go through. Okay. So that's all regarding that question. Now we will move on to the fifth question in our series. So the question is, what is the greatest danger in breech presentation? So from obstetrics and gynecology, so if there is a breech presentation, what is the greatest danger, greatest risk? So the option number A, option prolapse of foot, option number B, prolapse of cord, option C, prolapse arm, option D, precipitate labor. So what is the greatest danger in breech presentation? So the answer is cord prolapse or prolapse of the cord. Okay, so we know that a major complication of the breech presentation is the cord prolapse. That means where the umbilical cord drops down below the presenting part of the baby and becomes compressed. So the risk for cord prolapse varies, depends on the type of breech. So in incomplete or the footling breech, it carries the highest risk of cord prolapse. So this is another important point. Highest risk for the cord prolapse is happening which type of breech presentation, that is the incomplete or footling breech presentation, that is 15 to 18%, while the complete breech is lower at 4 to 6%, and the frank breech is uncommon, that is 0.5%. Okay, so the risk is high with the incomplete or the footling breech, then minimal with the breech, complete breech presentation, and very minimal, that means uncommon, with frank breech presentation. Okay. Now we are seeing the sixth question in our series from the central nervous system. So which ICP monitoring method is the most accurate? So be careful, which is the most accurate ICP monitoring method? Easy question. So the options are option number A, epidural catheter, option number B, intraventricular catheter, option number C, subarachnoid catheter, and option number D, intravertebral catheter. So which ICP monitoring is the most accurate? So definitely answer is option number B, that is the intraventricular catheter. So we know that the gold standard for the ICP monitoring is through an intraventricular catheter. So the three main types of ICP monitor are this is an additional information for you. So the three main type of ICP monitor are external ventricular drain, that is the EVD, then the subarachnoid bolt, and the epidural bolt. Okay, so these are some additional information I am giving you. You can refer in detail later. So these are the three main types of ICP monitor. Okay, so the answer for our question is intraventricular catheter. So you know that intraventricular catheters, they will be resting in the lateral ventricles, and it can be inserted through a hole in the skull. Okay, and can be advanced to the lateral ventricle. So moving on to the seventh question in our series. So concentration of xylocaine, which is used for local anesthesia in muscle or nerve biopsy, is. So here in the question they have given the procedure, that is for the muscle biopsy or the nerve biopsy, and in this case the local anesthesia will be given with xylocaine, and the question is how much percentage of xylocaine, concentration of xylocaine is used for this type of anesthesia. So the options are option number A 5%, option number B 10%, option number C 2%, and option number D 1%. So the usual question what we can see in the previous examinations is like for the surgery for giving spinal anesthesia, how much silocaine can be given. So in here my question is for the local anesthesia, how much percentage of concentration of silocaine is commonly used. So what is the answer? Answer is option number C, that is 2%. Okay. So we know that lidocaine, otherwise known as the lignocaine, which is sold under the brand name of silocaine, is a local anesthetics of the amino-amide type. Okay, it is of amino-amide type. So it is also used to treat ventricular tachycardia also. You know that lidocaine also is a drug of choice for the ventricular arrhythmias. Then the efficacy profile of the lidocaine as a local anesthetic is characterized by a rapid onset of action and intermediate duration of efficacy. So why lidocaine is used as a local anesthetic? That is because of its rapid onset of action and intermediate duration of efficacy. So therefore lidocaine is suitable for infiltration, block and surface anesthesia. Okay, infiltration, block and surface anesthesia. So that's all regarding that question. Now we will see the 8th question in our series. Which among the following is not a stage of dengue fever? Okay. So we know that there are certain stages for the dengue. So you have to find out which is not a stage of dengue fever. So the options are febrile, option number B critical, option number C convalescent, and option D hemorrhagic. So which is not a stage of dengue fever? So the answer is option number D, that is hemorrhagic. So this may confuse you because you know that dengue, hemorrhagic fever and all you have heard before. So that will, it's not coming under the stages of dengue fever. So we will see the stages of dengue fever. So dengue, it begins abruptly after a typical incubation period of 5 to 7 days. So this is the incubation period of dengue, and the course follows 3 phases, that is the febrile phase, the critical phase and the convalescent phase. Okay, so this is the incubation period 5 to 7 days and the 3 phases febrile, critical and convalescence. So I am explaining to in very short these 3 phases. The first phase, you know that the febrile phase. So the febrile phase, the fever typically lasts for 2 to 7 days. As the name indicates, this is the fever phase, and there will be fever which lasts for 2 to 7 days and can be biphasic. Then comes the next phase, that is a critical phase. So the critical phase of the dengue begins at defervescence and typically lasts 24 to 48 hours. So after this febrile phase, there comes the critical phase and it can last up to 24 to 48 days. So what is the peculiarity in critical phase is that most patients, they will clinically improve during this phase, but those with substantial plasma leakage can within a few hours develop severe dengue as a result of a marked increase in the vascular permeability and also develop severe hemorrhagic manifestations. Okay, so hemorrhagic manifestations can be seen in critical phase. So here this is very crucial, and the condition of the patient will be depend upon the substantial plasma leakage. If it is more, there will be chances of effusion, collection of fluid everywhere in the body cavities, and it is highly fatal, this critical phase. Okay, and after comes the convalescent phase. So as the plasma leakage subsides, the patient enters the convalescent phase and begins to reabsorb extravasated intravenous fluids and pleural and abdominal effusions, and hemodynamic status stabilizes during this period, and the convalescent phase rash may desquamate and be pruritic. Okay, so you know that there are chances of developing rashes in dengue fever, so that is coming during the convalescent phase. Okay, so this is very short regarding the phases of dengue. So you have to study in detail about these phases because any forms of questions can be asked from these areas. So whatever is very important I have pointed here in detail, you can refer later. Okay, so don't forget about these 3 phases: febrile, critical and convalescent. So moving on to the 9th question. This is from the orthopedics. So fetal bones are examples of which type of bones? So question is fetal bones are examples of which type of bones? Okay, so I'll be giving you some options. Option A, that is a lamellar. Option B, that is woven. Option C, cortical. And option D, cancellous. So fetal bone is an example of which type of bone? So the answer is option number B, woven bone. Okay, so I'll be explaining this now. So you know that there are two major type of bones. Okay, so woven and lamellar. So keep these 2 points in the mind. First one is the woven and the next one is the lamellar. So what is a woven bone? So woven bone is a immature, poorly organized and not very strong. Okay, so immature, poorly organized bone, and it is not strong. So it is found in the fetal bones and the fracture callus. Okay, fetal bones and fracture callus are the examples of woven bones. Then comes the another set of bones, that is the lamellar bone. So lamellar bone, it is the normal mature bone. So it is highly organized and very strong. So there are two subtypes of lamellar bone, which includes the cortical bone, and which is found in the diaphysis or the shaft of the long bone such as femur, and comes the cancellous bone which is found in the metaphysis of the long bones and the smaller bones such as the calcaneum. Okay, so cortical means in the diaphysis and shaft of long bones, cancellous which is seen in the metaphysis and smaller bones such as calcaneum. So these are the two major type of bones, that is woven and lamellar. Lamellar again cortical and cancellous. So the answer for our question is woven bone. Okay, so that's all regarding this question. Moving on to the 10th question in our series. Which of the following statement is true of cervical cancer? So the question is regarding cervical cancer. You have to find out the true statement from the options. So the first option, prevalent in industrialized countries. Then option B, potentially preventable. Option number C, more prevalent among sexually inactive persons. And option number D, associated with a familial cancer syndrome. So what is the true statement regarding cervical cancer? So the answer is definitely option number B, that is potentially preventable. So we all know that a unique quality of the cervical cancer is that it is potentially preventable when vaccination, proper screening and treatment are appropriately administered. So you know that the one and only cancer that can be prevented through vaccination is the cervical cancer. Okay, so the other options we will see. It is a disease that is associated with sexual activity. In the question it has given sexual inactivity, but it is always associated with sexual activity. So it is generally less prevalent in the abstinent. Okay, early onset of sexual activity and multiple sexual partners increases the risk of cervical cancer, likely because of the increased potential for HPV exposure. Okay, human papilloma virus exposure. So you know the etiology of the cervical cancer. So HPV exposure is one of the main etiology, and chances of HPV exposure are high with multiple sexual partners and early onset of the sexual activity. Okay, so then the other option, cervical cancer is no more prevalent in the industrialized countries. So it is also less associated with the familial cancer syndrome. Rather, the cervical cancer is more closely linked to sexually transmitted HPV infection, what we have already explained. Okay, so these are the some important points that you can remember regarding the cervical carcinoma in exam point of view. So moving on to the 11th question in our series. So the question is, a pneumothorax that causes mediastinal shift and compression of the functioning lung is called. So here the question is asking regarding a type of pneumothorax, and the characteristics of pneumothorax is mediastinal shift is happened because of the compression of the functional lung. So the options are option number A, primary pneumothorax, option number B, secondary pneumothorax, option C, traumatic pneumothorax, and option D, tension pneumothorax. So what is the answer? pneumothorax that causes the mediastinal shift and compression of the functioning lung? Answer is obviously option number D, that is a tension pneumothorax. So we will see the difference between these pneumothoraxes. So a pneumothorax, it is an abnormal collection of air in the pleural space between the lung and the chest wall. So you know that what is a pneumothorax. So in a minority of cases, a one-way valve is formed by an area of the damaged tissue, and the amount of air in the space between the chest wall and the lung increases. So this is called a tension pneumothorax. Okay, so this can cause a steadily worsening oxygen shortage, and there will be low BP. So this leads to a type of shock called obstructive shock, which can be fatal unless reversed. So very rarely both lungs may be affected by the pneumothorax, and it is often called a collapsed lung, although that term may also refer to atelectasis. Okay, so very important points you are getting out of this slide. So tension pneumothorax, that because of the one-way valve, a one-way valve will be formed, and there will be collection of the air within this space, and this air can or the fluid can compress the functioning lung and can cause the worsening of the oxygen level, and there will be low blood pressure. And the type of shock which can happen here is the obstructive shock, and it is very fatal. Okay, and as a result it can result in the collapsed lung, otherwise known as the atelectasis. Okay, so that is a tension pneumothorax. Then we will see the other options. That is first one is a primary spontaneous pneumothorax. So what is a primary spontaneous pneumothorax? So it is one that occurs without an apparent cause and in the absence of significant lung disease. Okay, so smoking increases the risk of primary spontaneous pneumothorax. So as the name indicates, it is a primary. There is no secondary features, or there is no secondary causes for the development of pneumothorax, and it is a spontaneous one. So smoking increases the risk for the spontaneous pneumothorax. Then comes a secondary spontaneous pneumothorax, and this occurs in the presence of an existing lung diseases. And the underlying causes for the secondary pneumothorax are COPD, asthma, and tuberculosis. Okay, so I think you understood the difference between primary spontaneous pneumothorax and the cause is smoking, and the secondary spontaneous pneumothorax and the causes are COPD, asthma, and tuberculosis. Then comes the another one, that is a traumatic pneumothorax. So this can develop from physical trauma to the chest, that including a blast injury, or from a complication of a healthcare intervention. For example, during the ICD insertion or during any other procedures that is advancing to the lungs, then there is a chances like the patient can go to traumatic pneumothorax. Okay, sometimes like CVP insertion, those areas, those timings. Okay, so you are getting information regarding primary, secondary, traumatic, and tension pneumothoraxes from this question. Okay, so we will see the 12th question in our series. So the question is, sensory nerve endings located within the alveolar walls are named as. So the question is regarding a sensory nerve ending which is located within the alveolar walls. So the options are pulmonary stretch receptors, option number B juxtapulmonary receptors, option number C irritant receptors, and option number D proprioceptors. So from this question you are getting information regarding some nerve endings which can involved in the normal respiratory process. So this is a normal physiology. So here the question is regarding the sensory nerve ending which is present in the alveolar walls. So what is the answer? So basic physiology, and the answer is option number B, that is a juxtapulmonary receptor. Juxtapulmonary receptor. So I'll be explaining regarding these four receptors now. So first of all, the question, juxtacapillary receptors or the J receptors or pulmonary C fiber receptors are the sensory nerve endings located within the alveolar walls in the juxtaposition of the pulmonary capillaries of the lung. So, and are innervated by the fibers of vagus nerve. So before going to the function, we will see what is a juxtacapillary receptor. It is otherwise known as the J receptor or the pulmonary C fiber receptor. So These are sensory receptors, and where they are placed in the juxtaposition, in the same position to the pulmonary capillary of the lung, and it is supplied by the vagus nerve, fibers of the vagus nerve. Then J receptors respond to events such as pulmonary edema, pulmonary emboli, pneumonia, congestive heart failure, and barotrauma, that is a pressure trauma, which causes a decrease in oxygenation and thus lead to an increase in respiration. So what is happening is, when there is a condition where there is a decrease in the oxygenation because of the conditions what I have explained here, the J receptors will be stimulated, and it will allow the person to have an increase in the respiration to compensate for the oxygen loss. Okay, so that is a function of J receptors. So because these receptors have been found in the walls of the bronchi, the larynx, and the nose, they appear to be part of the widespread population of nociceptors found in the moist tissue. So for this reason, they are now usually referred as the pulmonary C fiber receptors. So this is the reason they are also known as the pulmonary C fiber receptors. Okay, so the juxtacapillary receptors, I think you got the point. So now we will see the other options what I have explained in the question. The other one receptor was the pulmonary stretch receptors. So as the name indicates, stretch receptors, these are present in the smooth muscles of the airways, which responds to excessive stretching of the lung during large inspiration. Okay, so it responds to the excessive stretching. As the name indicates, it is a stretch receptor. So what is happening is, once activated, they send action potentials through the large myelinated fibers of the vagus nerve to the inspiratory area in the medulla and apnoistic center of the pons. Okay, understood. So in the medulla inspiratory center, it will be activated. It will be sending the action potentials, and in the pons, that the apnoistic center. Okay. So regarding the other option, that is a irritant receptor. So as the name indicates, irritant. So these are stimulated by noxious gases, dust, or the cold, and it is lies between the airway epithelial cells. Okay. So as the name indicate, irritant receptors will respond to the irritants like noxious gases, cold, and inhaled dust. So what is their physiology is like, they send action potentials via the vagus nerve, leading to bronchoconstriction. So if there is a noxious stimuli, that can lead to bronchoconstriction and increased respiratory rate. Okay, so that is the irritant receptors, and that probably causes cough. They can cause the cough and expiration reflex and other laryngeal reflexes. Okay, they will stimulate these actions, like cough will be produced, and that noxious thing will be coughed out, and expiration reflexes can be stimulated, and laryngeal reflexes also can be stimulated. So these are the points that you should remember about the irritant reflexes. So you have got information regarding irritant receptors, then J receptors or the juxtapulmonary receptors, stretch receptors, etc. Okay. Now I think we can move on to the next question in our series, that is the 13th question. So which of the following important endocrine functions do the kidney undertake? So here the question is regarding the endocrine function of the kidney. Endocrine functions of the kidney. So the options are: option A, secretion of thrombopoietin; option number B, 1-alpha hydroxylation of vitamin D; option number C, production of aldosterone; and option number D, production of atrial natriuretic peptide. So which is the endocrine function of the kidney? From the options you need to find out. So be careful, there are chances that you can mistaken the options. So function of the kidney. So the answer is option number B, that is 1-alpha hydroxylation of vitamin D. So what is this process called? So that we will be seeing in the options. So you know that the important endocrine functions of the kidneys include: the first one is the production of erythropoietin, not thrombopoietin, that is TPO. This is EPO, that is erythropoietin. Then second, the alpha 1 hydroxylation of vitamin D, and the next one is the secretion of renin. Okay, so vitamin D production, secretion of the renin, not the aldosterone, and the production of erythropoietin and not the thrombopoietin. So these are the main important endocrine functions. So what is a 1-alpha hydroxylation? So the 1-alpha hydroxylase plays an important role in the calcium hemostasis by catalyzing the synthesis of the active form of vitamin D, that is 125 dihydroxy vitamin D, in the kidney. Okay, so this is the important pathway in the formation of the calcium hemostasis. It is by the catalyzing synthesis of the active form of vitamin D. Okay, then the other options we will see, that is a TPO, that is the thrombopoietin. Thrombopoietin is produced primarily in the liver parenchymal cells, with much smaller amounts being produced in the kidney and bone marrow. So primarily it is produced by the liver and very small amounts are produced by the kidney and the bone marrow. Then other option, that is the aldosterone. So aldosterone, you know that it is a steroid hormone which is synthesized in and secreted from the outer layer of the adrenal cortex, that is a zona glomerulosa. Okay. Aldosterone from the zona glomerulosa of the adrenal cortex. Then another option was the atrial natriuretic peptide, or the ANP. So it is synthesized and secreted by the cardiac muscle cells in the walls of the atrium in the heart. So these cells contain volume receptors which responds to the increased stretching of the atrial wall due to increased atrial blood volume. So then whenever there is an increase in the volume of in the atrial chambers, these receptors are stimulated and the process will happen. So this ANP will be released. That is the atrial natriuretic peptide will be released. Okay, so these are some additional points you are getting out of this question. Now we can move on to the second last question in this series. Which of the following is an opportunistic infection that can occur in advanced HIV infection? So here the question is regarding an opportunistic infection that can happen in advanced HIV patients. Options are option number A, pneumocystis carinii pneumonia. Option number B, herpes zoster. Option number C, toxoplasmosis. And option number D, all of the above options. So think about opportunistic. What is an opportunistic infection? And HIV. So the answer for this question is obviously easy question. Answer is option number D, that is all the above options like pneumocystis carinii, herpes zoster and toxoplasmosis. So what is an opportunistic infection? Opportunistic infection is an infection which is caused by the pathogens that take the advantage of an opportunity not normally available. So so in normal individuals, this opportunity for these pathogens to enter into the body is not available, but whenever there is a damage in the patient's immune system like HIV and all, there comes an opportunity for these pathogens like bacteria, fungi, parasites or the virus to cause the infection. So such infections are called as opportunistic infections. Okay, so HIV, it is a virus that targets the T cells of the immune system. Okay, and as a result, the HIV infection can lead to progressively worsening immunodeficiency, and which is ideal for the development of opportunistic infection. Okay, so HIV is targeting on the T cells of the immune system, and there will be worsening of the immune system, and there gets the opportunity for these pathogens to develop opportunistic infections. Okay, so that also nice question. Now we will move on to the last question in our series, another very easy question. Which among the following is not an antifungal drug? So the options are option number A, fluconazole. Option number B, amphotericin. Option number C, voriconazole. And option number D, valganciclovir. So by the process of elimination itself, you can omit some options and you can come to the answer. But why I have included this question is I will be explaining regarding the indications of these drugs. So that also you can learn from this question. So the answer for this question is obviously valganciclovir. Okay, valganciclovir. So as a name indicates, it is a viral antiviral drug. So valganciclovir, it is an antiviral medication which is used to treat the cytomegalovirus infection in those patients with HIV or following the organ transplantation. So this is important for cytomegalovirus infection, and for the organ transplantation we are giving an antiviral drug which is known as the valganciclovir. Okay, so it is often used long term as it only suppresses rather than cures the infection and it can be taken by mouth. Okay, it will suppress the infection and it won't cure the disease. Okay, so that's regarding the valganciclovir. Then the other options, like we have seen fluconazole. You know that it is a common antifungal medication which is used for a number of fungal infections, which includes candidiasis, blastomycosis, coccidiodiomycosis, cryptococcosis, histoplasmosis, dermatophytosis, and tinea versicolor. And other option, that is the amphotericin B, it is also an antifungal medication which is used for the serious fungal infections and leishmaniasis. Okay, so keep this point in mind, leishmaniasis. Whenever there is a point like leishmaniasis, think about amphotericin B. So the fungal infection it is used to treat include mucormycosis, aspergillosis, blastomycosis, candidiasis, coccidioidomycosis, and cryptococcosis. Okay, so think about amphotericin B when there is an option like leishmaniasis is there in the options. Then the final option, that is a voriconazole. So voriconazole, it is an antifungal medication which is used to treat a number of fungal infections which include aspergillosis, candidiasis, coccidioidomycosis, histoplasmosis, penicillosis, and infections by the scedosporium or the fusarium. Okay, so these are some additional points that you can remember in exam point of view. So with this question from the pharmacology, we are coming to the end of another session of the AIIMS NORCET series. Hope all these 15 questions what we have discussed today will help you for a better preparation for the upcoming examination. So stay tuned with us for the next video to come. We'll be uploading the next video within short period of time. So keep in touch with us, study well, all the very best for your upcoming examinations. Stay tuned till that time. Bye.